with FLT3 inhibitions, there is two important things. The first thing is that there is no several inhibitors. Midostaurin, I mentioned midostaurin, which was one of the first ones, but there is new development in that field, and we have now a short list, but a list of several molecules that could inhibit FLT3. And which is really important to consider is that all these inhibitors are not targeting exactly the same kinases. All are targeting FLT3. They are FLT3 inhibitors. But some of them are multi-kinase target agents, like midostaurin or sorafenib, for instance. So it could happen that when using a multi-kinase targeting agent, you could get some benefit or some beneficial effects by targeting other kinases than FLT3. This is so-called off-target effects. And it is maybe important in the case of sorafenib or midostaurin. So when the midostaurin trial results were available, a lot of investigators, including myself, asked the question of what could have been the effect of midostaurin in FLT3 negative patients because of this potential off-target effect of a multi-kinase inhibitor like midostaurin. And the other thing which is important, and in relationships with what I mentioned before concerning the secondary event, FLT3 mutation could be a secondary event, is that you cannot expect probably to cure a patient by simply inhibiting FLT3. Because if FLT3 is a secondary event, you have also to target the driver event. So this is the rationale to combine FLT3 inhibition to other treatment. First, to standard treatment, which was present before, and maybe in the next future, to new treatments, to combine novel drug to FLT3 inhibition.
Not all FLT3 inhibitors are the same. There are many drugs which have been developed in the guise of being FLT3 inhibiting, which is based on their ability to inhibit the enzyme in vitro or in cell-free systems. But no enzyme inhibitor is completely specific because many of our enzymes in our bodies are similar to the other ones, and these drugs are not completely specific. So these FLT3 inhibitors differ along certainly their FLT3 inhibitory spectrum. Do they inhibit FLT3 only? Again, not really feasible, but mainly. Or do they inhibit FLT3 and a lot of other enzymes that may or may not be relevant in the pathophysiology of AML? And there are other issues. Is the drug protein bound? Is it readily bioavailable? Does it have side effects? So FLT3 inhibitors are not all the same. And the most important initial difference I would submit is whether or not the inhibitor in question hits both the internal tandem duplication mutation only, or whether it hits that one as well as the tyrosine kinase domain mutation. So midostaurin, for example, which is one of the first putative FLT3 inhibitors tested, is A, highly protein bound, B, does inhibit both the FLT3 ITD and the tyrosine kinase domain mutation, and C is fairly promiscuous in other enzymes that it inhibits, including c-KIT and even non-tyrosine kinases like protein kinase C, which was why it was first developed. Actually, midostaurin was used in solid tumors because it was a protein kinase C inhibitor, and that was thought to be beneficial in solid tumors. Turns out not to be the case, but when it was found by Griffin, Weisberg, and others to be a FLT3 inhibitor, then it started to be developed in AML.